Welcome back to the Deep Dive, where we take complex clinical knowledge and, well, we give you the essential blueprint. Today, we are undertaking a really deep exploration into the assessment and management of hepatic disorders.
Yeah, and for a lot of people, the liver just feels like this black box of biochemistry.
It does. But if you really stop and think about its role, it's the master regulator.
It is the ultimate metabolic engine, and if the liver fails, you don't just have a local problem, you have a systemic collapse. I mean, the entire body's ability to process nutrients, to detoxify waste, manage fluids, clotting,
Yeah.
it all just shuts down.
And that complexity is precisely why this topic can feel so overwhelming for students.
Absolutely.
So our mission today is to cut through all of that complexity. We're going to give you a structured clinical shortcut based entirely on the foundational source material. We're going to map out the pathophysiology, dissect those tricky diagnostics like LFTs, and establish that critical nursing process framework you need to manage these life-threatening conditions.
Things like cirrhosis, varices, and of course, hepatic encephalopathy.
Exactly. So let's jump in. And I think the best place to start is just appreciating the sheer workload of this organ.
It's massive. If you just look at the anatomy, it's the largest internal organ. We're talking 1,200 to 1,500 grams in an average adult.
And it sits in that upper right quadrant of the abdomen, right? Tucked behind the ribs.
Snugly in there, shielded by the ribs. And it's structurally divided into 4 lobes. But the really unique part, the thing that's so critical to understanding liver failure, is its blood supply.
It's that dual system.
Precisely. It's a dual system, and it tells you everything you need to know about its function.
So 80% of that blood flow comes from the portal vein.
Right. And think of this as the body's, recycling and delivery system. It's draining the entire GI tract, so it's bringing in all the nutrients from your food, but
also all the bad stuff.
all the bad stuff, toxins, bacteria, particulate matter. And this blood is relatively oxygen poor.
And the other 20%.
That comes from the hepatic artery. And that's your high-octane, oxygen-rich blood, or the hepatocytes, the liver cells. They need that for their massive metabolic demands.
So where these two supplies meet, inside those capillary beds called the sinusoids, that's where all the action is.
That's where the magic and the cleaning happens. It is. And living right inside those sinusoids are the Kupffer cells.
Okay, so what are those?
They're a type of fixed macrophage. In fact, they are the most common and, you could argue, the most crucial phagocytes in the entire human body.
And their job is just immediate cleanup.
Immediate and vital. They engulf bacteria and any foreign debris that's coming in with that portal blood before it can ever get into the systemic circulation. And this is so important. When liver function is compromised and that portal blood flow slows down, the ability of these Kupffer cells to clean that blood just plummets.
Which immediately explains why liver failure is such a huge infection risk.
A dramatic infection risk.
Okay, that makes sense. Now let's move to the liver's, its actual job description. These immense metabolic functions. We have to start with its role as the ultimate blood sugar regulator.
It absolutely controls blood glucose levels, and it does it with 3 distinct processes. So after you eat, when your glucose levels are high, the liver converts that glucose into glycogen for storage. That process is glycogenesis.
And then when you skip a meal and your blood sugar starts to drop, it does the reverse.
Exactly. It breaks that stored glycogen back down into glucose. That's glycogenolysis.
But what if you're starving or the demands are really high and you've run through all your glycogen stores? What's its last trick?
It employs gluconeogenesis,
Creating new glucose.
creating brand new glucose from non-carbohydrate sources, mostly amino acids or lactate, for muscle breakdown. This flexibility is what ensures the systemic glucose supply is maintained, even if it's at the cost of breaking down other body tissues.
All right, next up is the detoxification function, specifically ammonia conversion. And this really is the difference between life and, well, a severe coma.
It is life critical. Ammonia is a metabolic byproduct. It's generated when we use amino acids, and it's also produced in huge quantities by bacteria in our intestines as they break down protein and urea.
And it's a potent neurotoxin.
A very potent neurotoxin. The liver's job is to convert this ammonia into urea, which is then safely excreted by the kidneys. A failure right here is the central issue in hepatic encephalopathy.
Let's discuss protein. The liver is just a massive factory for proteins.
Absolutely. It synthesizes almost all of our plasma proteins. The most famous one is albumin, which is essential for maintaining plasma oncotic pressure.
So without enough albumin, fluid just leaks out of the blood vessels.
It leaks out of the vascular space,
Yeah.
leading directly to edema and ascites. Equally important are the clotting factors, including prothrombin. And because the synthesis of a lot of these clotting factors requires vitamin K, the liver synthetic capacity is directly measurable.
By the prothrombin time, or the INR.
Exactly. It gives us a really powerful diagnostic tool.
What about its role in fat metabolism?
It's complex. It breaks down fatty acids for energy. It forms ketone bodies, which is especially critical when glucose is limited, like in uncontrolled diabetes or prolonged starvation. It's also where the body synthesizes cholesterol, lecithin, and the lipoproteins that carry fats in the bloodstream.
And we can't forget the warehouse function, the storage.
Right. It's a huge storehouse for essential vitamins,
Mm.
particularly the fat-soluble ones A and D, but also vitamin B12 and key minerals like iron and copper. This storage capacity provides a buffer against, temporary dietary shortages.
The last major function links all the way back to the assessment signs we look for: bile formation and bilirubin excretion.
Bile is produced continuously by the hepatocytes. It contains water, electrolytes, cholesterol, and critically, bile salts. And these bile salts, which are synthesized from cholesterol, are essential for emulsifying fats in the intestine.
They allow for digestion and absorption.
Exactly.
And the system that conserves these salts, the enterohepatic circulation, it's incredibly efficient.
It's a beautiful closed loop. Hepatocytes secrete the bile. It travels to the intestine. Most of those bile salts are then reabsorbed in the distal ileum, carried right back to the liver via the portal circulation, and then they're immediately recycled.
That conserves a lot of the liver's energy.
It does. It limits the need for constant new synthesis.
Okay, finally, let's talk about the pigment that really reveals liver damage. Bilirubin. Where does it come from, and how is it processed?
Bilirubin is that yellow pigment that results from the breakdown of hemoglobin. That's done by the reticuloendothelial system, which includes those Kupffer cells we mentioned.
So the hepatocytes grab this bilirubin from the blood.
They remove it, and then they chemically bond it, or conjugate it, to something called glucuronic acid. This step is what makes it water-soluble.
And only the conjugated bilirubin can be excreted.
Only the conjugated form. It gets secreted into the bile, travels to the small intestine. Once it's there, it becomes urobilinogen, which is mostly excreted in the feces. That's what gives stool its brown color.
And a little bit is reabsorbed and excreted in the urine.
A small portion is. But if any step in this whole pathway fails, the pigment backs up, and that's what leads directly to jaundice.
Understanding that healthy liver's workload, it immediately clarifies why failure causes just systemic chaos. So when we approach a patient, what are the immediate factors like age that we have to consider?
Well, the gerontologic considerations, which are outlined in Chart 43-1 in the source material, they're crucial for dosing and for prognosis.
Yeah.
As patients age, the liver actually decreases in size and weight, and importantly, total hepatic blood flow is reduced.
So what's the clinical implication of that decreased flow?
Reduced drug clearance, medications that the liver metabolizes, and that's a huge list of drugs. They're going to stay in the system longer.
So you have to use reduced dosages.
You have to use reduced dosages and monitor very closely for signs of toxicity. On top of that, older patients have an increased risk of gallstones because of higher cholesterol secretion in bile, and if they contract hepatitis C, the disease progression tends to be faster.
The health history is always the starting point for uncovering risk factors. What kind of exposures are we aggressively looking for?
We're investigating exposures to any hepatotoxic substances. This goes beyond just alcohol and IV drug use, which relate to infectious agents like Hep B and C. We need to ask specifically about industrial chemicals and high-risk medications.
Can you give us a few examples of common medications that can cause drug-induced liver injury?
Sure. High doses of acetaminophen, which is the leading cause of acute liver failure in the U.S., but also common agents like ketoconazole, certain anesthetics, valproic acid. We need a really detailed accounting of all substance use.
And we absolutely cannot skip the family history here.
No, and Chart 43-2 in the text really emphasizes getting a 3-generation family history. This is vital for disorders like Alagille syndrome, which is autosomal dominant, or metabolic storage diseases like hemochromatosis,
The excess iron.
or Wilson disease, which is excess copper. Those are autosomal recessive. Catching that genetic predisposition early can prevent irreversible damage.
Let's talk about the symptom assessment. Liver dysfunction symptoms are, well, they're notorious for being vague, right? Malaise, weakness, fatigue, before the really overt signs like jaundice appear.
And this is why nurses have to be so alert to these non-specific complaints. We need to ask about pruritus, that's intense itching, abdominal pain, fever, anorexia, and, confusingly, sometimes weight gain.
Which is from edema or the increased abdominal girth from fluid accumulation.
Exactly.
And when that synthetic machinery in the liver starts to fail, the bleeding symptoms appear.
That's the coagulopathy. We look for hematemesis, melena, or hematochezia. But even simple observation can reveal easy bruising, petechiae, those little pinprick red spots, or ecchymoses, the larger bruises.
And the neuroendocrine system, what do we see there?
These are key indicators of detoxification failure. Changes in mental acuity, personality shifts, irritability, sleep disturbances. Often they can't sleep at night, but they're sleepy all day. All of that points directly toward toxin buildup.
And in men, specifically.
In men, the failing liver can't inactivate estrogens, so you see signs like decreased libido, gynecomastia, and testicular atrophy.
Okay, moving to the physical assessment. What are the telltale visual signs of chronic liver disease?
Well, we inspect for pallor from anemia, jaundice in the skin and sclerae, and skin excoriation from constant scratching due to those bile salts. But you have to look closely at the vasculature.
The spider angiomas are really distinctive.
They are. These vascular arterial spiders, they usually appear above the waistline on the face, neck, upper trunk. They're small red lesions with these little radiating capillaries.
And we also check for palmar erythema.
Liver palms, exactly. It's a reddening of the palms that's related to hormonal changes in vasodilation.
And for male patients, those hormonal changes are visibly reflected.
Yes, the gynecomastia and testicular atrophy are essential to document. It confirms the impact of the liver's inability to metabolize those androgens and sex hormones.
Neurologic status is a continuous assessment priority, especially when you're suspecting hepatic encephalopathy or HE.
We check for a gross tremor, but the most diagnostic physical sign is asterixis.
The involuntary hand flapping.
Exactly. You ask the patient to extend their arms and dorsiflex their wrists, and their hands will involuntarily flap or fall forward for a moment. We also have to assess cognitive function, memory, abstract thinking, sometimes on a daily basis.
Finally, the abdominal assessment. How do we differentiate a healthy liver from a diseased one just on palpation?
A normal liver edge, if you could even feel it, is sharp and firm.
Yeah.
If it feels soft and tender, that typically indicates acute hepatitis. The liver is swelling rapidly and stretching its capsule.
And if it's small and hard?
That suggests advanced late-stage cirrhosis. There's significant scarring and shrinkage. Tenderness is almost always a sign of acute or recent inflammation.
What about the nursing assessment for ascites? How do we confirm that large volume fluid accumulation?
We rely on percussion for shifting dullness. So when the patient is supine, the fluid pools out to the sides. When they roll to their side, the fluid shifts with gravity, and the area that was dull before now becomes tympanic or air-filled.
And that confirms it's free fluid in the abdomen.
Right. And if the volume is huge, we can check for a fluid wave. But the technique here is crucial. The nurse has to place the ulnar side of their hand, or have an assistant place their hand, firmly down the midline of the abdomen.
Why is that step so important?
It prevents the wave from just transmitting through the abdominal wall fat. It ensures that the wave you feel on the other side is actually the fluid moving. And of course, daily abdominal girth and weight measurements are just non-negotiable for monitoring.
So when we order those liver function tests, the LFTs, there's a crucial, almost sobering concept that nursing students have to understand. These tests are often lagging indicators.
That's probably the single most important clinical insight in this section. LFTs may only become abnormal once over 70% of the liver parenchyma is already damaged.
70%? That's incredible.
It is. It really underscores the insidious nature of liver disease. The liver has this immense reserve capacity that can mask early damage for a long, long time.
So what does that mean for how we interpret the results?
It means we have to look at trends, not just the single snapshot. We have to interpret the results within the full clinical context and remember that a lot of non-hepatic disorders can affect these values. The nurse's role is to educate the patient and monitor that trajectory.
Okay, so let's break down the key serum enzymes, starting with the most specific one, ALT.
ALT, or alanine aminotransferase, is highly specific to liver disorders. When we see a high ALT, we can be pretty confident the damage is primarily hepatocellular. It's damage to the liver cells themselves. It's the standard for monitoring the activity and progression of hepatitis or cirrhosis.
And then there's AST, which is its less specific sibling.
Right. AST, or aspartate aminotransferase, is found in a lot of high metabolic activity tissues, the heart, skeletal muscle, kidney, and the liver. So while it is elevated in liver disease, if the AST rises way out of proportion to the ALT, we have to start thinking about damage to other organs.
A heart attack or a massive muscle injury.
Exactly. That difference in specificity helps us differentiate the source of the injury.
And GGT, gamma-glutamyl transferase, is often used to confirm another finding.
GGT is associated with bile stasis or cholestasis, and it's a very strong indicator of alcoholic liver disease. Its biggest clinical utility, though, is confirming that an elevated alkaline phosphatase is coming from the liver.
Because alk-Phol can be high in bone disease, too.
Exactly. So if alk-Phol is high and GGT is also high, the problem is hepatic in origin.
Okay, let's quickly review the categories in Table 43-1 from the text. We've talked about pigment studies, so bilirubin.
We measure total, direct, which is conjugated, and indirect, which is unconjugated bilirubin. Jaundice is clinically visible when that total bilirubin gets above 2.0 milligl. And if you see bilirubin in the urine, that tells you it's a conjugated water-soluble form, which usually points toward an obstruction or severely impaired excretion.
Then we have protein studies, albumin and globulin.
Albumin synthesis drops off sharply in chronic liver disease. Low albumin leads to that fluid shifting and edema. Globulins, on the other hand, often increase because of chronic inflammatory processes, which can sometimes lead to that characteristic reversal of the AG ratio.
The prothrombin time and INR aren't just about bleeding risk, they're direct measures of the liver's synthetic capability.
This is so crucial. A prolonged PT-INR tells us the liver isn't making the clotting factors it needs to. And if we give the patient supplemental vitamin K and the PT-INR still doesn't correct,
That's a very bad sign.
it's a very poor prognostic sign. It means the hepatocyte damage is so severe that the cells simply cannot respond. It indicates an irreparable loss of function.
And the last major marker, ammonia.
Ammonia levels rise when the liver loses the ability to convert this toxin into urea. Elevated ammonia correlates very strongly, though not perfectly, with the development and progression of hepatic encephalopathy.
Now, beyond blood work, the liver biopsy is still the gold standard for diagnosis. What is the single biggest safety concern before that procedure?
Bleeding. The liver is incredibly vascular, and the most common risk is peritonitis from blood or bile leaking into the abdomen. So, coagulation studies PT-INR, platelets must be obtained, and any abnormalities have to be corrected, often with vitamin K or plasma, before the biopsy is ever performed.
And if the patient has significant ascites or a coagulopathy that you can't correct, are there alternatives to the standard percutaneous route?
Yes. We can use alternative routes like the transvenous approach, which usually goes through the jugular vein down into the hepatic vein, or a guided laparoscopic approach.
Yeah.
These minimize the risk of bleeding into that peritoneal space, so they're much safer options for high-risk patients.
And finally, the non-invasive diagnostics have advanced significantly.
They really have. Imaging like CT, MRI, and ultrasound can assess the size, blood flow, and identify any space-occupying lesions. But the cutting edge right now is non-invasive fibrosis tests.
Like elastography.
Elastography, or magnetic resonance elastography, MRE. These tests measure the stiffness of the liver, and they provide a very accurate, repeatable way to monitor the extent of fibrosis and cirrhosis progression without needing to do repeat biopsies.
Let's dedicate some time now to jaundice, which is really the hallmark physical sign of liver pathology. It happens when serum bilirubin exceeds 2.0 milligdl, and we categorize it based on where the failure is located.
And that location matters immensely because it dictates the treatment.
Yeah.
First, you have hemolytic jaundice. This occurs before the liver even gets a chance to handle the bilirubin.
So the liver itself is healthy in this case?
Yes, the liver function is totally normal, but there's a massive, rapid destruction of red blood cells hemolysis, which you might see in a transfusion reaction or a sickle cell crisis. The liver is just overwhelmed by the sheer volume of unconjugated bilirubin arriving in the plasma.
And clinically, how does that present?
The urine will be free of bilirubin because unconjugated bilirubin isn't water-soluble, but the urobilinogen level will be elevated.
Okay, so contrast that with hepatocellular jaundice, where the damage is to the cells themselves.
Here, the hepatocytes are damaged from viruses, toxins, alcohol, and they just can't effectively take up or conjugate the bilirubin. These patients are often severely ill with anorexia and profound malaise, and you see really high AST and ALT levels from the cellular necrosis.
But this type can be reversible.
It's often reversible if the underlying cause, like an acute viral hepatitis, is resolved.
And then there's obstructive jaundice, which is really a mechanical backup problem.
This is often the most clinically striking type. There's a block, either from intrahepatic swelling or an extrahepatic block like a gallstone or a tumor, that just stops the bile from flowing. The conjugated water-soluble bilirubin backs up, gets reabsorbed into the blood, and stains the entire body yellow.
And the clinical shortcut for confirming an obstruction, check the stool and urine color.
Exactly. The cardinal signs of obstructive jaundice are deep orange and foamy urine. That's from the excretion of conjugated bilirubin, and light or clay-colored stools because no bile pigment can reach the intestine.
And these patients also have intense pruritus.
Intense pruritus because those bile salts are retained in the skin, plus a real intolerance to fatty foods because they lack the bile salts for digestion.
Finally, we noted hereditary hyperbilirubinemia like Gilbert syndrome.
These are just genetic variations that result in impaired bilirubin clearance. They're typically harmless. And what's crucial for diagnosis is that the LFTs and the liver histology are entirely normal, which differentiates them from true liver disease.
Now, the second major manifestation, and really the source of most of the life-threatening complications, is portal hypertension.
pH is the defining characteristic of advanced cirrhosis. It's an elevated pressure in the portal venous system that results from scarred fibrotic tissue obstructing the flow of blood through the liver.
So the blood just backs up.
It backs up and it causes collateral circulation to form as the body tries to find alternate routes back to the vena cava.
What are the two major immediate clinical consequences of that massive mechanical backup?
Splenomegaly, an enlarged spleen, which can lead to something called hypersplenism, but most dangerously, ascites and esophageal varices.
Ascites, the accumulation of fluid in the peritoneal cavity, it can swell the abdomen with up to 20 liters of fluid. It's a highly resistant, complex, self-perpetuating cycle that involves 4 concurrent mechanisms.
Right. First, you have the mechanical problem. Portal hypertension increases the hydrostatic pressure within the splenic circulation, and that mechanically forces fluid out of the vessels and into the peritoneal space.
And second is the hormonal component.
The damaged liver fails to metabolize aldosterone. This leads to hyperaldosteronism and significant renal retention of sodium and water.
And the third and fourth factors relate to protein and volume.
The third is the protein loss. Decreased albumin synthesis. Low albumin drops the serum osmotic pressure, which makes it even easier for fluid to leak out of the vascular space.
And fourth, the body misinterprets this whole situation.
It does. It interprets this leak as volume depletion, which causes systemic vasodilation. And that, ironically, signals the kidney to retain more fluid via the renin-angiotensin system, which just worsens the whole retention cycle.
Assessing this is non-negotiable nursing care. We mentioned daily weight and abdominal girth.
Correct. The earliest and most reliable indicators of fluid accumulation are weight gain and an increased girth. We assess for shortness of breath, striae, or stretch marks. For diagnosis, we're looking for that shifting dullness and the fluid wave.
Remembering that the assistant technique is vital for an accurate reading.
Absolutely vital.
Medical management starts non-invasively with nutritional therapy.
The goal is to achieve a negative sodium balance. This requires a strict 2-gram low-sodium diet. So avoiding table salt, processed foods, canned or frozen items that aren't specifically prepared low sodium. This is very challenging for patients, but it's crucial.
And there's a major nursing alert regarding salt substitutes, isn't there?
Yes. We have to advise patients to avoid salt substitutes that contain ammonia. In a patient with compromised liver function, this extra ammonia load can directly precipitate hepatic encephalopathy.
And what about potassium-containing substitutes?
Those should also be avoided if renal function is impaired, which is very common in advanced liver disease.
When diet isn't enough, we introduce pharmacologic therapy.
Diuretics are the cornerstone here, and they're successful in about 90% of patients. Spironolactone, which is an aldosterone antagonist, is the first-line agent.
It's potassium-sparing.
It is, which is important because hypokalemia can also trigger encephalopathy.
Right.
We can cautiously add a loop diuretic like furosemide, but we have to monitor very closely for hyponatremia.
Which diuretics are strictly contraindicated and why?
Ammonium chloride and acetazolamide. Because they alter the body's acid-base balance and can increase ammonia levels, they have to be avoided entirely. The risk of precipitating hepatic encephalopathy and coma is just too high.
And what are the parameters for safe diuresis? How quickly is too fast?
We have to monitor weight loss very closely. If the patient has peripheral edema, the maximum safe daily weight loss is 1 kilogram, or 2.2 pounds.
And if they only have ascites with no peripheral edema?
Then the limit is stricter, 0.5 to 0.75 kilograms a day, so about 1.1 to 1.65 pounds. Losing fluid faster than that risks volume depletion and potentially triggering an acute kidney injury or hepatorenal syndrome.
The intervention of last resort before shunting is paracentesis. This often involves removing massive volumes of fluid, 5 to 6 liters or more. Why must this procedure be followed up immediately with an IV infusion of salt-poor albumin?
This is a critical nursing intervention. Rapidly removing large volumes of fluid leads to a sudden drop in the effective arterial blood volume.
And without intervention, that can cause serious problems.
Serious problems. That drop can trigger post-paracentesis circulatory dysfunction, which activates the entire vasoconstrictive system and leads to renal dysfunction and a very rapid reaccumulation of the ascites.
So the albumin infusion helps pull fluid back into the vascular space.
It does. It stabilizes the circulating volume and protects the kidneys.
If the ascites remains completely refractory, the patient might move to a transjugular intrahepatic portosystemic shunt, or TIPS.
The TIPS procedure involves placing a stent inside the liver to create a direct pathway between the high-pressure portal vein and the low-pressure hepatic vein. This mechanically bypasses the fibrotic liver, dramatically reduces portal hypertension, and effectively treats that refractory ascites.
If it's so effective, why is it often considered a second-line therapy or even a palliative one?
Because of the risk trade-off. By shunting blood around the liver, we reduce the portal pressure, yes, but we also reduce the liver's ability to detoxify that blood.
So it significantly increases the risk of HE.
It significantly increases the risk of developing or worsening hepatic encephalopathy. It's a calculated risk management decision between treating the fluid overload versus the neurological risk.
Finally, the home care checklist, chart 43 through 8, outlines key discharge instructions.
And this requires detailed education. Patients have to understand the crucial role of strict adherence to that low-sodium diet, the signs of fluid overload, so weighing themselves daily and recording any increases, and the potential side effects of their diuretics.
We also teach them to watch for the earliest signs of encephalopathy.
The subtle mood or sleep changes, and to understand which medications and substances, like alcohol-containing cough mixtures and NSAIDs, are absolutely contraindicated. This is preventative nursing at its best.
Esophageal varices represent the acute, life-threatening consequence of portal hypertension. These are dilated, fragile, tortuous veins in the submucosa of the lower esophagus and stomach. What makes them so prone to rupture?
They're essentially collateral blood vessels that form in the low-pressure veins of the esophagus and stomach. They're trying to divert that backed-up portal blood, but these vessels are structurally delicate. They are not designed to handle the high pressure and volume being forced into them by the obstructed liver. It makes them incredibly fragile.
What are some of the common mechanical triggers for a catastrophic hemorrhage?
Well, anything that suddenly increases pressure. So muscular exertion like heavy lifting, vigorous coughing, straining at stool, vomiting, or even sneezing.
And local irritation can do it too.
Absolutely. Esophagitis, highly acidic or irritant fluids, especially alcohol, or drugs that interfere with mucosal integrity like salicylates or NSAIDs can trigger a bleed.
If a rupture occurs, the consequences go way beyond just hemorrhagic shock.
It's a rapid cascade of events. First, you have the immediate massive hemorrhagic shock tachycardia, hypotension, decreased perfusion to vital organs. Second, that massive amount of blood in the GI tract is broken down by intestinal bacteria.
And that creates a huge nitrogen load.
A vast and sudden nitrogen load, which the failing liver cannot process. This drastically spikes the serum ammonia levels and almost guarantees a severe acute hepatic encephalopathy.
Diagnosis relies on endoscopy, but what's the crucial screening recommendation?
Any patient newly diagnosed with cirrhosis should undergo a screening endoscopy. If no varices are found, they should repeat the screening every 2 to 3 years.
And if small varices are detected,
then repeat screening every 1 to 2 years is mandated. The goal is to identify and treat large varices before that first highly lethal bleed can occur. The hepatic venous pressure gradient, or HVPG, is also measured. A pressure above 10 millimeter Hg indicates clinically significant pH.
Okay, let's discuss the immediate pharmacological management of an acute bleed. We have 2 major vasoconstrictors.
We prefer octreotide, which is a synthetic form of somatostatin. It works by causing selective vasoconstriction of the splanchnic arterial bed, primarily by inhibiting the release of glucogen. This effectively reduces portal pressure.
And it's the preferred first-line agent.
It is, due to its high efficacy and relatively mild adverse effect profile, which is usually just some transient abdominal cramping or mild hypoglycemia.
What about vasopressin? It's potent, but it carries significant risk.
Vasopressin is used in urgent situations because it causes rapid generalized vasoconstriction, which does reduce portal pressure. However, the critical side effect is coronary vasoconstriction.
So it's contraindicated in patients with coronary artery disease.
Absolutely. It has to be used with extreme caution, often combined with IV nitroglycerin to prevent coronary ischemia.
And to prevent a bleed from happening in the first place, we turn to prophylaxis.
That's the long-term role of beta blockers, specifically non-selective agents like propranolol, nadolol, or carvedilol. They decrease portal pressure and are highly effective for preventing both the first bleeding episode and rebleeding. But remember, they are not used during the acute hemorrhage itself.
Endoscopic therapy has seen a real revolution. Endoscopic variceal ligation, EVL, has now replaced sclerotherapy. Why is that?
EVL, or variceal banding, is the current treatment of choice. A small rubber band is placed around the varix, causing localized necrosis and sloughing, which effectively closes off the vessel.
And it's just safer.
It's preferred over sclerotherapy, which is injecting hardening agents, because EVL results in significantly lower rebleeding rates and fewer complications. It's a safer and more durable solution.
Now, if the bleeding is torrential and immediate control is needed, we sometimes use the highly invasive and high-risk balloon tamponade tubes.
This is a temporary measure, and it requires the highest level of vigilance. The Sangstein-Blakemore tube, for instance, has gastric and esophageal balloons to directly compress the bleeding varices.
And the safety alert here is all about the airway.
Yes, the absolute primary nursing risk is airway obstruction and asphyxiation if the tube gets displaced or if the gastric balloon ruptures. For stuporous patients, endotracheal intubation before insertion is often necessary to protect that airway.
And what are the time limits for its use?
It should be used for the shortest possible duration, preferably less than 12 hours, just until a definitive therapy like EVL or TIP-MPS can be implemented.
Reviewing the nursing management from Table 43.2, what are the critical nursing actions during this emergency phase?
The focus is on stabilization and preventing complications. We're monitoring vital signs or hemorrhagic shock every 15 minutes, preparing for and assisting with blood transfusions and vitamin K administration, and maintaining a calm, quiet environment to reduce the patient's anxiety and strain.
And if balloon tamponade is being used?
Meticulous oral and nasal hygiene is essential, and the nurse has to continuously monitor for any tube displacement and prevent the patient from pulling it out.
Hepatic encephalopathy is that critical neuropsychiatric manifestation associated with hepatic failure, and it's driven by portal hypertension, shunting blood away from the liver, and by the key toxin, ammonia.
The pathology is very clear. The failing liver can't convert ammonia to urea. So ammonia, which is sourced from protein metabolism and from intestinal bacteria breaking down protein in urea, it bypasses the liver via shunts and travels directly to the brain,
Causing a reversible metabolic encephalopathy.
Exactly.
What are the common precipitants that can suddenly push a chronic liver patient into acute HE?
The most common one is a GI bleed, because it provides a sudden, massive nitrogen load. Other factors include consuming a very high-protein diet, although our current recommendations are more nuanced now, and acute infection, uremia, and, critically, medications.
Like sedatives or certain diuretics?
Yes, sedatives or potassium-losing diuretics, which can cause hypokalemia, and that exacerbates the toxic effects of ammonia.
The progression is staged, according to Table 43.3. Stage 1 is really subtle.
Very subtle. Often just lethargy, a subtle euphoria, or maybe some mild impairment in their handwriting or drawing skills.
But Stage 2 is more obvious.
It is. Increased drowsiness, disorientation, inappropriate behavior, marked mood swings. And this is the stage where we typically see the classic signs, asterixis, that involuntary hand flapping, and phytor hepaticus.
Which is that sweet, slightly fecal odor on the breath.
Right, it's from volatile sulfur compounds that the liver can't clear.
Stage 3 involves marked confusion and stupor, and that progresses to Stage 3, which is a full coma. How does the nursing staff monitor this progression on a daily basis?
Daily, timed neurologic checks are essential every 4 to 8 hours. We use the constructional apraxia test, which is shown in Figure 43.13. You just ask the patient to draw a simple star or a geometric figure.
And any deterioration in that ability to draw or write gives you objective evidence of progression?
Graphic objective evidence. And in Stage 4, the asterixis actually disappears as the patient becomes flaccid.
Medical management centers on lowering that ammonia level. Lactulose is the first-line agent. How does it work?
Lactulose is a synthetic disaccharide that isn't absorbed. In the colon, it acidifies the environment, which converts ammonia, NH3, into the ammonium ion, NH4+.
And since that ammonium ion is trapped, it can't be absorbed.
It's trapped. It's not diffusible across the intestinal wall, so it gets expelled from the body through defecation. The nursing goal is very clear. The patient should achieve 2 to 3 soft stools per day.
What's the safety alert regarding lactulose dosing?
We have to monitor very closely for watery diarrhea. That's a sign of a medication overdose, and it can lead to severe dehydration and electrolyte imbalances. If the patient has diarrhea, the dose has to be titrated down.
Antibiotics are also used adjunctively.
Yes, agents like rifaximin, neomycin, or metronidazole are used to reduce the number of ammonia-forming bacteria in the colon, which thereby decreases the ammonia load produced in the gut.
We have to spend some time on the critical update to nutritional management from chart 43 to 4. The old practice of strict protein restriction is now considered dangerous. Why the shift?
This is a crucial area of change in nursing practice. Protein restrictions should be avoided. We now know that the risk of inducing severe protein malnutrition and muscle-wasting sarcopenia, it far outweighs the immediate risk of worsening HE, especially since we have effective agents like lactulose.
So the goal is now a high protein intake.
A high protein intake. We're aiming for 1.2 to 1.5 grams of protein per kilogram of body weight per day. And we deliver that in small, frequent meals, often including a late-night snack to reduce overnight catabolism.
Why are safety and monitoring so important in the nursing care plan for HE?
Because the patient has an unpredictable neurological status. We have to maintain a safe environment, padded side rails, remove any obstacles, and ensure frequent surveillance. Restraints are discouraged because they can increase agitation.
And we're monitoring INO and vitals.
Every 4 hours, that's standard. And respiratory management is key. We encourage deep breathing and position changes to prevent pneumonia and atelectasis, which can be fatal. If stage 50 is reached, mechanical ventilation might be necessary just to protect the airway. Okay, we should briefly touch on the 4 phases of infectious hepatitis. We start with the viral replication phase, which is asymptomatic. Then we move to the praecteric or prodromal phase, that's the vague, flu-like symptoms, anorexia. That's followed by the enteric phase, jaundice, dark urine, and finally the convalescent phase, which is resolution.
Starting with hepatitis A virus, or HAV, the fecal-oral route infection.
HAV is transmitted by ingesting contaminated food or liquids. It's common in areas with poor sanitation. The incubation is 2 to 6 weeks. The course is typically mild, flu-like, lasts 4 to 8 weeks, and recovery is common. Crucially, it does not progress to chronic liver disease or a carrier state.
And prevention is through vaccination, which is detailed in chart 43 to 5, and post-exposure immune globulin.
Yes, vaccination is recommended for all children in high-risk groups. For those who are exposed, IG provides passive immunity if it's given within 2 weeks. Management is entirely supportive. Rest during the acute stage, nutritious small meals, and strict hand hygiene to prevent transmission.
Hepatitis B virus, or HBV, poses that chronic risk.
HBV is transmitted through blood, sexual contact saliva, semen secretions, and also perinatally from mother to infant. Chart 43 to 7 lists the high-risk groups: healthcare workers, IV drug users, hemodialysis patients, and people with multiple partners. Up to 15% of adults can develop a chronic infection, which carries a high risk of cirrhosis and liver cancer.
We diagnose HBV using specific markers.
HBsAg, the surface antigen, indicates an active infection. HBag indicates active viral replication and high infectivity. And the presence of anti-HBs indicates immunity, either from vaccination or a resolved infection.
And prevention.
Standard precautions: vaccination, which provides 90–95% protection, and post-exposure prophylaxis with HBIg plus the vaccine.
Treatment for chronic HBV often involves complex pharmacologic agents.
We use drugs like petylated alpha interferon or oral nucleoside analogs like indicavir and tenofovir. The goal is to suppress viral replication, minimize infectivity, and reduce inflammation. And we maintain a high protein intake, that 1.2, 1.5 UKG day, for nutritional support.
Hepatitis C virus, or HCV, has been completely revolutionized by modern medicine.
It really has. HCV is primarily parenteral IV drug use and contaminated needles. It's the most common chronic bloodborne infection nationally. The course is often asymptomatic, but it has a very high rate of chronicity, which leads to cirrhosis and HCC. It is the most common reason for liver transplantation in the U.S.
So tell us about the revolution in treatment. This is a massive insight into clinical progress.
Well, historically, HCV treatment involved interferon and ribavirin. It was a regimen that lasted a year, caused severe flu-like side effects, depression, and it only achieved a cure rate of about 50–60%.
And today,
direct-acting antivirals, or DAAs, like lidipasvir, sofosbuvir, have completely changed the landscape. These are short, 8 to 12-week oral therapies that achieve a sustained virologic response or a cure in over 90% of patients.
which means fewer people progressing to end-stage disease.
Significantly fewer.
Briefly, HDV and HEV.
HDV is incomplete. It needs HPV to replicate. Treatment is typically long duration, high-dose interferon. HEV is fecal-oral, waterborne. It resembles HAV, but it does not cause chronic liver disease.
And finally, non-viral hepatitis, toxic and drug-induced.
Toxic hepatitis is from exposure to toxins like carbon tetrachloride. It leads to extensive parenchymal destruction and requires immediate removal of the agent. Drug-induced hepatitis, again, is often caused by an acetaminophen overdose, causing acute liver failure. Immediate withdrawal of the offending medication is mandatory.
Acute liver failure, or ALF, is a catastrophic event. It's a sudden, severe impairment in a previously healthy person, and it's defined by neurologic dysfunction and a prolonged PTINR of 1.5 or higher, with no prior liver disease, typically evolving in less than 26 weeks.
And we classify it based on the speed of encephalopathy onset. Hyperacute is 0.7 days, acute is 8.28 days, and subacute is 28.72 days. While the mortality is very high, the lesion is potentially reversible if the patient can survive that acute phase.
And management is focused entirely on ICU support and preventing secondary injury, especially in the brain.
Cerebral edema is the #1 cause of death in ALF stage 4. Management involves aggressive ICP monitoring, the use of osmotic diuretics like mannitol, and careful sedation. We administer antidotes like N-acetylcysteine for acetaminophen. But ultimately, the survival mechanism of choice is often an emergency liver transplantation.
Okay, so contrast that rapid process with hepatic cirrhosis, which is a chronic progressive disease.
Cirrhosis involves the irreversible replacement of normal, functioning liver tissue with diffuse fibrotic scar tissue. It disrupts the organ's entire architecture. We classify it by cause. Alcoholic cirrhosis, which is the most common, post-necrotic cirrhosis, which follows chronic viral hepatitis, and biliary cirrhosis, which is scarring around the bile ducts, often from a chronic obstruction.
The etiology has broadened significantly beyond just alcohol, hasn't it?
Yes. Nutritional deficiency and the increasing epidemic of obesity-related liver disease, NAFLD, and NASH are now major contributors to cirrhosis incidence and mortality.
Prognosis relies on the Child-Pugh classification, which is table 43-5. What does that scoring system assess?
It's a standard tool that scores 5 parameters: the severity of the ascites, total bilirubin, albumin levels, the PTINR, and the degree of encephalopathy. It then assigns a grade A, B, or C to predict expected survival and the complexity of management.
Clinically, we talk about compensated versus decompensated cirrhosis, as shown in chart 43-9.
Compensated patients have those vague symptoms: indigestion, vascular spiders, mild splenomegaly, but they're able to maintain most of their metabolic functions. Decompensated patients exhibit overt failure, profound muscle wasting, jaundice, severe ascites, purpura from the coagulopathy, and hypotension. All the complications we've discussed, varices, HE, fluid shifts, they all occur in that decompensated phase.
Let's elaborate on the complications, particularly the domino effect of ascites leading to other problems.
So portal obstruction causes the blood to back up, leading to varices, caput medusae, those distended abdominal veins, and hemorrhoids. But critically, that pool of acidic fluid creates a perfect environment for infection.
Which can lead to spontaneous bacterial peritonitis.
SBP, exactly. And SBP often acts as the trigger for the highly fatal hepatorenal syndrome, which is an acute functional kidney failure that does not respond to fluid resuscitation.
We also need to reinforce the risk of vitamin deficiency and anemia.
Because bile salt secretion is impaired, the absorption of the fat-soluble vitamins A, D, E, and K is significantly reduced. Vitamin K deficiency directly causes hypoprothrombonemia and bleeding.
And patients also commonly have deficiencies in B vitamins.
Yes, B-complex vitamins, vitamin C, and folic acid, especially in alcohol-related disease. This necessitates comprehensive supplementation for all of them.
Okay, finally, let's look at the detailed nursing management plan for cirrhosis, which is in chart 4310. The care plan is extensive.
It focuses on 3 main pillars. First, promoting rest to reduce the metabolic demands on the already struggling liver. Second, improving nutritional status, high calorie, high carb, and that now standard 1.2 to 1.5 billion a day of protein. And third, reducing risk of injury, which is due to both bleeding and altered mentation.
What are the key nursing interventions for skin and bleeding risk?
For skin care, pruritus is managed by frequent repositioning every 2 hours. We avoid harsh, irritating soaps, use emollients, and ensure their nails are kept short and smooth to prevent excoriation.
And for bleeding risk?
We use an electric razor, a soft toothbrush, and we apply sustained pressure to all venipuncture sites. And we must monitor all their output for occult blood and check for any increasing bruising.
Primary cancer of the liver, or hepatocellular carcinoma, HEC, is strongly linked to chronic liver disease, particularly cirrhosis that's secondary to chronic Hep B or Hep C infection.
HCC is often insidious and frequently unresectable by the time it's discovered. Alpha-fetoprotein, or AFP, is used as a screening tumor marker. But it's important to remember that liver metastases cancer that spread from the GI tract, the breast, or the lung are about 2.5 times more common than primary liver tumors.
And the clinical signs are vague until the late stages. A dull RUQ ache, weight loss, anorexia. Management is often palliative.
Non-surgical options include chemotherapy that's delivered directly via a hepatic artery infusion pump. For obstructive symptoms like pain or intractable pruritus, a percutaneous biliary drainage can palliate the symptoms by reestablishing bile flow. Surgery, like a lobectomy, is only possible if the tumor is localized and small.
For life-threatening end-stage liver disease, ESLD, the final intervention is liver transplantation, or OLT. How is organ allocation prioritized?
Allocation is determined by the Melendez score, the model for end-stage liver disease. This score incorporates objective lab values, bilirubin, PTINR, and creatinine. It assigns priority to the sickest patients who are most likely to die without a transplant.
And for HCC, there are strict criteria.
Yes. The strict Milan criteria must be met, for example, a single tumor less than 5 centimeters, to ensure the cancer hasn't spread beyond a curative reach.
Post-transplant care is an intensive juggling act, and it's dominated by preventing infection and rejection.
Infection is the #1 cause of mortality post-transplant, especially fungal and pulmonary infections, and that's due to the aggressive immunosuppression. We enforce strict aseptic technique for all lines and drain care and maintain a pathogen-free environment.
And rejection requires complex medication regimens.
We use what's called triple therapy, combining corticosteroids, a calcineurin inhibitor like cyclosporine or tacrolimus, and an anti-proliferative agent. The goal is immune suppression without toxicity. Tacrolimus is often preferred over cyclosporine because it has a better nephrotoxicity profile.
A common later complication is hypertension. How is that managed in the context of all this immunosuppression?
It's managed specifically with calcium channel blockers, like nifedipine or amlodipine. And that's because these agents have minimal interaction with the cytochrome P450 enzyme system in the liver, which is responsible for metabolizing those crucial immunosuppressive drugs.
Beyond the physical care, the psychosocial adjustment, which is in Chart 4311, is immense.
Patients face significant anxiety and depression. Nurses have to reinforce the absolute necessity of lifelong adherence to that complex immunosuppressant regimen. Missed doses can trigger a fatal rejection. We also emphasize frequent blood tests and regular follow-up, including ophthalmologic exams due to the long-term steroid use.
Our final condition to cover, liver abscesses.
These pyogenic abscesses occur when an infection reaches the liver, often via the portal or the biliary system. Clinically, they present as signs of sepsis fever, chills, malaise, but often without clear localizing pain initially. Diagnosis requires a guided aspiration and culture, and treatment involves 5E antibiotics and drainage management.
And the nursing priority here
is monitoring for signs of rupture, a sudden, intense abdominal pain, or deterioration in vital signs.
This comprehensive deep dive into hepatic disorders has taken us through the liver's entire clinical landscape. If you're a student preparing for practice, we really need to distill this vast amount of material into the 3 critical areas requiring your most vigilant focus when you're managing a hepatic patient.
The first area, and it's non-negotiable, is bleeding risk. You have to be continuously monitoring for the earliest signs of coagulopathy or variceal hemorrhage. So, checking PTINR trends, looking for occult blood, and managing patients gently to avoid any trauma.
The second is fluid and electrolyte management. This means meticulous monitoring of ascites progression, those daily weights and abdominal girths, and carefully balancing diuretic therapy while you're watching for hyponatremia, hypokalemia, and any signs of potential renal failure.
And the third, which is the most subtle but maybe the most life-saving, is neurologic status. Early detection of hepatic encephalopathy is absolutely crucial. You have to look past the obvious and focus on those subtle shifts. The inability to write a neat signature, a slight mood change, or the onset of asterexis. Never, ever dismiss confusion as just getting old.
And that brings us to our final thought. The liver's enormous reserve capacity means that disease is often silent until 70% of its function is already lost. This emphasizes that recognizing the seemingly simple, nonspecific signs, like a patient who is suddenly too lethargic to draw a star figure or whose pruritus is worsening dramatically, that is the key clinical shortcut that prevents the catastrophic, life-threatening outcomes of a variceal bleed, acute kidney injury, or hepatic coma. Mastering that assessment cascade is truly mastering care for this population.